Hi everybody, I'm Stacy. Welcome to my channel. Let's talk about end-of-life symptoms. I want to talk about it again and again and again so that you're prepared to give that education. Things that you're teaching to your families that they will forget and that they will need more education on and sometimes demonstration. So let's talk about it. And if you like what you see here, then I ask that you like, subscribe, and follow for more. And I read your comments. Maybe I don't get back to answering you as quickly as I should sometimes with life and everything like that, but I do read everyone's comments and I do answer them as quickly as I'm able. Anything that I say here is just my opinion and my experience and does not replace the advice of an MD. Take what resonates with you, leave what doesn't, and like the psychics say, and let's get into it. Let's talk about it. So I have had a lot of experience with people in death and dying where they get to the end of life and the symptoms start happening and the death process starts progressing. And this is when patients' family members will panic. They will become anxious. They will forget the things that you guys have been talking about. And this is when they need you to give them back their power and help them regain their confidence. Because a lot of times they know what to do. You've given them the power to do it, and you just need to remind them and walk them through it so that they can do it themselves. And you need to be present to be able to do that with them. It's really important in hospice that when we are getting at end of life, that we are providing demonstration and that we have our family members return demonstrate in the home settings so that they can feel confident that they had somebody witness them do it. That's not just administering medications, that is emptying Foleys. We do things like Pleurex drains in the home, and we do try to empower family members to do those things too. Sometimes those families are on it and they have been well prepared in the hospital, and by the time they get home, they're very versed in understanding on how to do those procedures that they need to do for their loved one. Sometimes they've been doing it before their loved one came onto hospice. Some of them have been hanging IV meds, flushing the lines. They're very, very well versed in those things, but some families are not competent to do those things, and it's really important in the home setting that we are demonstrating and allowing our family members to demonstrate back. But let's talk about symptoms that need managing and that we need our family members to be able to manage in the home confidently. So the things that happen at end of life are often pain, shortness of breath, anxiety, fever. Those are the types of things that are going to happen. Constipation. Believe it or not, constipation at end of life should still be something that we're managing. Sometimes families don't want you to put a suppository in or do an enema when somebody is in the active phase of dying. They don't want you to be doing that stuff because it feels traumatic to them. And I totally can support that idea for a family member. You know, if a person is in their active phase of dying though, do know that something like nausea or constipation could be very uncomfortable for a patient, and it could be very necessary to go ahead and alleviate those symptoms and relieve them and help the family to relieve those symptoms. So the medications that we often provide in a comfort kit deal with constipation, nausea, and vomiting, pain, shortness of breath, and fever. So those are the kinds of things that we provide a comfort kit for, an emergency kit, a backup kit, if you will. And once we activate the use of that emergency kit, now we're going to provide that medication in a little bit higher quantity for the patient, depending on how often they're using it. In end of life, a common symptom that occurs is a fever, especially in the active phases of dying. A person will develop a very high fever. We do provide Tylenol suppositories for managing that fever, and it is okay to give those Tylenol suppositories. Sometimes, you know, when you have a fever, you don't feel very comfortable. A family member pointed that out to me, and I thought that was a very valid point. If we have a fever when we're feeling normal, we don't feel good when we have a fever, right? So it's reasonable to think that maybe a person in the active phase of dying, we can't possibly always know if it's uncomfortable for them. You can tell if a patient is uncomfortable. You can tell by the things that they're doing with their face, moaning, restless movements. There are going to be signs and symptoms that a patient is not comfortable. So we can do things like administer Tylenol. It's really good to pull some blankets off when a person starts having a fever. You can put cool cloths on the pressure points. Some good places to do that is the forehead, the wrists. You can put it on the neck, behind the knees, at the ankles. Those are good places to put cool cloths. When a fever breaks, it can cause shivering. So a lot of times a patient will start shivering, and when a person is having symptoms and a person is witnessing those symptoms, a person who loves their people, it is hard for them to witness those symptoms and not want to be proactive about it. So it's important as hospice nurses that we are compassionate in that we provide education on how to manage those symptoms and what those symptoms are going to possibly look like, and how to tell when a person needs intervention. You can always preemptively, if a person has a fever, give them a Tylenol suppository. You're likely not able to swallow Tylenol at this point or take ibuprofen or any of those things that we would normally do when a person gets a fever, right? So we do provide Tylenol suppositories. The thing about it is, a lot of family members, again, don't want you to give that suppository at end of life. And, they don't want you to be moving their person around and causing unnecessary discomfort. Another thing that can cause a fever, though, the first thing that happens is, there's a center in our brain that controls our temperature regulation. And when we are beginning to die, when we are dying actively, the center in our brain that controls that regulation is not working properly a lot of times. And so there will be a high fever or a normal temperature. And sometimes the medications that we give don't do much to change that. Again, I still recommend administering those medications when you're thinking about keeping a person comfortable, especially if they seem restless or they seem uncomfortable. Do something about it, absolutely. If a family absolutely does not want you to, then don't, but do give them alternative things they can do to help with fever management, such as cool cloths and taking off some blankets and just putting a sheet on the patient and those sorts of things. Again, though, when a person is constipated, that can also cause a fever to be there. Constipation is a pretty serious thing. So we want to make sure that we are managing that throughout the care of our patients while they're on service with us. While they're on hospice, we want to make sure that they're on a bowel regimen and that we're paying attention to their bowel movements. It is really important. Constipation is a thing that can cause a lot of discomfort and restlessness in patients. Sometimes we don't take that seriously enough at end of life, but it is a serious, constipation is serious and it should be managed. So we do have a suppository that we can administer when a person is alert. We can use things like Senna, Docusate, Miralax, milk of magnesia. Constipation is very, very common when you're dealing with pain medication. And that includes opiates, NSAIDs, analgesics, Tylenol, Motrin, ibuprofen, morphine. Any of those things are going to slow down motility. So they're interrupting the pain receptors, but they're also going to slow down motility and make a person potentially be constipated. In fact, it's going to make him have difficulty with having a bowel movement, because as we get older, a lot of times our patients in the hospice setting are up in years, and so their motility is already possibly impaired. So you also have to be thinking about the fact that when you start adding routine pain medications into their care, now not only are we dealing with pain, but now we're dealing with the inability to evacuate the bowel, okay? Constipation is an important thing to manage. So it's really important that you have a good bowel regimen, that you're talking about this with your provider, with your doctor, because different medications are going to be effective in different disease processes. We also use things like lactulose. That's a heavy hitter. And so we just want to be talking to our doctor, and the doctor is going to understand the disease process and understand which constipation medicine may work best in the situation. Sometimes with opiates, they need a really strong laxative. They need a really good bowel regimen, and especially people who have chronic constipation on top of now taking an opiate. So when people get at end of life, when they stop moving around as much, it's not just the disease process that causes pain, immobility and deconditioning. That causes pain in our patients' bodies. When they're laying in bed and they're not moving and they're not using their muscles, they sometimes will have aching and pain, not just from their disease process, but also from the fact that they're not using their muscles. And so we have to think about that and managing those symptoms as well. When you turn a patient, often what you'll see then in this case is that when you're moving and turning a patient, they will say, oh, and when you stop moving them, they're not in pain. So in those cases, I often tell my family members that if they are going to move the patient to provide cares for them or reposition them, that they should administer their pain medications 30 minutes to an hour before they provide those cares to help decrease the pain that's going to come from doing those movements. Also, with certain disease processes, especially like your cancers, your patients are having bone pain. And that is a very difficult pain to manage. It takes a lot of tweaking for the doctors to get it right for the patients sometimes, because every person is different too. So the symptoms that are happening at end of life also have to be adjusted according to a person's needs and according to what they are used to. Some people are naive to opiates, and so it's not going to take a very high dose to get their pain under control initially. Some people have been taking pain medications for a long time. They've been in their disease process for a long time, and they have developed a tolerance to certain medications. So it's really important that when we're managing pain, that we're titrating those pain medications according to our patient's disease processes, according to their tolerance level, and with the doctor on a routine basis to get them comfortable. That's really important. Shortness of breath is another thing that comes with end of life in certain disease processes, and then at end of life in the active dying phase, sometimes the respirations become labored. And so that is where your opiates really come in and help decrease that respiratory effort. You know, when your patient is breathing with their whole shoulder and their whole body, they are really working a lot to do the breathing. So you want to make sure that you are medicating them to help decrease that respiratory effort and to make them more comfortable when they are having shortness of breath. So that is another thing that happens, is labored breathing, shortness of breath. And in our patients with COPD, your chronic obstructive pulmonary disease, sometimes a little bit of morphine is going to help their breathing relax too. And that's really important for people. I mean, when they have COPD, cranking up the oxygen is not going to help the respiratory effort. I will say also, though, not just at end of life, but with your patients who have chronic pulmonary diseases, you want to make sure that they're doing their respiratory exercises, that they're using their incentive spirometers, that they're using their CPAP or their BiPAP if they have it, because that can help manage those symptoms as well. That they're using their flutter valve device. You know, I can't ever remember what it's called. We used to call it the green pickle. But now they have all kinds of flutter valve devices that patients use when they have COPD. That helps kind of manage those symptoms. None of that is curative, but it will help manage those symptoms as end of life is going on. And if a person is higher functioning and they're earlier in their disease process, earlier in their dying process to where they're not necessarily active, we want to keep them doing the things that help them to breathe easier, right? So the flutter valve device, you want to have them blow into that periodically throughout the day. You want them to use that incentive spirometer. We don't want our patients to get respiratory infections, right? We want to help try to prevent those sorts of things. So while hospice is not aggressive, we do still provide care for our patients. It's really important that we are treating our patients as a whole person when they're in hospice and thinking about those things, encouraging them to use their inhalers and their breathing treatments and those sorts of things too. Those are things that can help with shortness of breath and oxygen. Now, again, with COPD, when you crank the oxygen, that's not necessarily going to help the shortness of breath. So you do want to be talking to the doctor about other things like steroids, breathing treatments, and those sorts of things to help alleviate some of those respiratory symptoms that come with disease progression. And eventually the morphine is really going to help in that process. Morphine is a really key oldie but goodie for our patients that are having pain and shortness of breath. Unless they're allergic to it, obviously. Make sure you know what your patients are allergic to. Never give something that your patient is allergic to. Always be paying attention to allergies and being in communication with your doctor about those sorts of things, because they know what can be used in lieu of the medications that we standardly use. Talking about anxiety and agitation, those are big symptoms that come at end of life. We call it terminal restlessness. Sometimes people get hallucinations, sometimes they will strike out at you, sometimes they just can't get comfortable. That's where we start using things like lorazepam, clonazepam, alprazolam. We're using the LAMs, we're using the benzodiazepines in end of life to manage anxiety, and some of them are long acting, some of them are shorter acting. And so it's really important that you're working with your doctor on the severity of the anxiety that's happening and the restlessness that's happening. Terminal restlessness is a big key that a person is advancing in their dying process. Agitation is something that we can manage with things like quetiapine and haloperidol and things like that. So those are the medications we use. Those are the types of symptoms that we're experiencing. If you have any other symptoms that you've seen that I missed, I would love to hear about it. I'm always loving to learn new things in my nursing journey. And if you like what you see here, then I ask that you like, subscribe, and follow for more. And always, always feel free to leave comments about things that you would like to discuss, things that you're curious about, questions that you have. I do read all of your comments, and I thank you so much for watching. I hope to see you soon. Bye-bye.